Hello everyone. In this seminar, we are going to discuss about mucoepidermoid carcinoma. Coming to the contents, this seminar we are going to see about introduction, historical overview, etiology, clinical features, histopathological features, immunohistochemistry, variants of tumor, differential diagnosis, clinical behavior, and prognosis, and treatment of the lesion. Coming to the introduction, mucoepidermoid carcinoma is the most common, which is about 29 to 34% of malignant salivary gland neoplasm, and the second highest frequency of occurrence among all salivary gland tumors. The name implies tumor is composed of mucosecreting cells and epidermoid cells. In varying proportions, clear cells are also seen in some cases. Historical overview, term given by Stewart, Foote, and Becker in 1945. Earlier in 1939, D and Tribody termed as a mixed epidermoid and mucosecreting carcinoma. In 1953, Foote and Fraser proposed the gradings of tumor depending on degree of cyst formation as opposed to solid growth, proportion of cell types, and presence or absence of cytomorphologic atypia. In 1968, Jacobson et al. Used the presence of invasion as the criteria for grading of tumor into high and low grades. In 1984, Asita et al. Used the conjunction of original and invasion criteria into borders with partial encapsulation or good circumscription, broad pushing borders with a limited invasion, infiltrative growth with permeation into surrounding tissue. Gray and co-workers classified tumor as common cell carcinoma with mucin positive cells with cellular pleomorphism as dominant. Coming to etiology, possible factors for development of mucoepidermoid carcinoma are therapeutic radiation, lipoidal installation, and presence of other foreign material. Clinical features, there is a wide age range this tumor can occur, which is about 2nd to 8th decade of life, showing slight female predilection, and the previous history of radiation therapy can also cause mucoepidermoid carcinoma. Asymptomatic solitary swelling can present. Parotid gland is the most commonly involved gland other than other major glands. The gender difference is more pronounced for patients with lesions of the tongue and retromolar areas. This is the graph showing distribution of patients with mucoepidermoid carcinoma by age, which is given by AFIP. Pain, facial nerve palsy, trismus, drainage from the ear, dysphagia, numbness of the adjacent areas, ulceration, fixation to the overlying skin are seen high-grade variant. In low-grade variant, tumor appear as slowly enlarging, painless, often contain cyst filled with viscid mucoid material. Minor salivary gland sites. Most common site is the palate, also occurs in buccal mucosa, tongue, floor of the mouth, retromolar pad areas. When bone is involved, numbness of teeth and cupping of bone occurs. These are the clinical images of the lesion. Lesion appears bluish or red purple, fluctuant, which is magenta in color. Mucus may be discharged from the lesion. Focal erythema or ecchymosis can be present. Granular or papillary masses, or it can be as hard masses. It may also arise from ectopic salivary gland tissue located in cervical lymph nodes. These are the anatomic distribution, which is given by AFIP registry. Macroscopic features, usually partially encapsulated and rarely completely encapsulation present. Cut surface is firm and pinkish or yellowish in color. Extreme induration is occasionally present. Cyst formation is evident. Cystic spaces contain viscid translucent mucoid material that may be blood tinged. Focal hemorrhage sometimes present. Histopathological features, there is a mixture of mucus producing cells and squamous epidermoid cells. Mucus cells contains about pale foamy cytoplasm stains positive with the mucin stains, mucicaramine and PAS, common in minor salivary gland tumors. These cells appear as round, cuboidal, ovoid, columnar, or goblet shapes. In local overview, these cells may be confused with sebaceous cells. The histopath image of the mucosals is in mucoepidermoid carcinoma. The epithelial mucin produces stains for mucicaramine and PAS and is resistant to diastase digestion. is Pastein and Mucoepidermoid. The histopath images. Epidermoid cells, which are polygonal intercellular bridges, rarely keratinization, is seen in intermediate cells, progenitor of both cells, small bacilli maternal cells with a little or no cytoplasm to slightly large ovoid cells with scant, pale, evenly distributed eosinophilic cytoplasm. Epidermoid metaplasia. Have clear cytoplasmic borders in areas of less cohesive cells. Reveal mucin and pass positive particles identified as glycogen. Dardick and co-workers suggested that the majority of intermediate cells represent highly modified myoepithelial cells that result from tumor induction. This is the image showing a combination of mucous cells, epidermal cells, and intermediate cells. In this image, there is some clear cells. Clear cells are large polygonal with sharply demarcated cytoplasmic borders. Lymphoid infiltrator are also seen. Histopathological grading given by Foot and Russell. They graded as low, intermediate, and high. In low grade, prominent cyst formation, which is cyst often rupture and produce inflammatory reaction. In intermediate, cyst formation is less prominent. In high grade, cyst component is very less, that is less than 20%. In low grade, minimal cellular atypia, mitosis are absent. In intermediate grade, cellular atypia may or may not be present. In high grade, nuclear pleomorphism, prominent nucleoli, and mitotic activity are noticed. In low grade, high proportion of mucous cells can be seen. In intermediate grade, all types of cells present within predominant intermediate cells. In high grade, solid islands of squamous and intermediate cells. Necrosis and perineural inflammation are also present. This is the grading system given by the Batsaki et al. In the year of 1990. They graded as grade 1, grade 2, grade 3. As grade 1 as low grade, grade 2 as intermediate, grade 3 as high. In grade 1, macrocyst and microcyst transitions with the excreted drugs can be seen. In grade 2, no macrocyst. If fewer microcysts, solid list of cells can be seen. In grade 3, no macrocyst, preponderantly solid, but maybe nearly all microcystic glandular. In grade 1, differentiated mucin producing cells and epidermoid cells often 1:1 ratio. Intermediate cell population minimal to moderate is focal. In grade 2, intermediate cell preponderance with or without epidermoid differentiation, mucin producing cells may be sparse. In grade 3, dedifferentiated cells difficult to find, especially mucin positive cells. In grade 1, daughter cyst proliferation from larger cysts can be seen. In grade 2, large depth population far less conspicuous. In grade 3, cell constituents range from poorly differentiated to recognizable epidermoid and intermediate to ductal type adenocarcinoma with epidermoid and intermediate cell participation. In grade 1, minimal to absent pleomorphism and rare mitosis can be seen. In grade 2, slight to moderate pleomorphism, few mitosis, nuclei and nucleoli are more prominent. In grade 3, considerable pleomorphism, prominent nucleoli, and easily found mitosis can be seen. In grade 1, broad front, often circumscribed invasion. In grade 2, invasive quality, usually well defined and uncircumscribed. Grade 3, unquestioned invasion, soft tissue, perineural and intravascular can be seen. In grade 1, pools of extracellular mucin with a stomal reaction, fibrosis, chronic inflammatory cells can be seen. In grade 2, chronic inflammation at periphery, fibrosis separates nest of cells and a group of nests. In grade 3, chronic inflammation is less prominent. Dysplasia of stoma may outline invasive clusters. Parameters used for grading intraoral mucoepidermoid carcinoma according to Hoffler et al. In 1991. Their parameters are intracystic component is less than 20%, is given the point as +2. Neural invasion present, given the point as +2. Necrosis present, given the point as +3. For mitosis, 4+ per high power field +3. Anaplasia +4. Low grade. Based on this parameter, they are graded as on the Low grade has the point of 0 to 4, and the intermediate grade has the point of 5 to 6, and high grade has 7 plus. Proposed grading system for mucoepidermoid carcinoma, Brandon et al. 2001. This they took the features as intracystic component less than 25%. They given the point as +2. Tumor front invades in small less than islands, given the point as +2. Pronounced nuclear atypia, point as +2. Lymphatic and vascular invasion, given the point as +3. Bony invasion as +3. More than 4 metastases per 10 high power field, given as +3. Perineural spread, given as point as +3. Necrosis, given the point as +3. Low grade, they given 0 of point of 0, they given as low grade, and the point of 2 to 3 as intermediate grade, and the point of 4 plus as high grade. This is the modified Healy Memorial Sloan Kettering Cancer Center, that is AFIP and a branding system for grading of salivary gland tumors. Immunohistochemistry, expression of P27 and K67 was assessed immunohistochemically in primary mucoepidermoid carcinoma of the intraoral minus salivary gland. Variants of the tumor: sclerosing mucoepidermoid carcinoma. Intense central sclerosis in the tumor can be seen. Inflammatory infiltrate of plasma cells, eosinophils, and lymphocytes presence. Causes for development of sclerosing variant are tumor infarction, extravasation of mucin resulting in reactive fibrosis. Intraosseous central mucoepidermoid carcinoma. Tumors arise centrally within the jaws. Hypothesis for pathogenesis: ectopic salivary gland tissue developmentally entrapped within the jaw. Axillary tumors arise from glands of sinus lining, odontogenic epithelium. Clinical features: middle-aged adults is most common, which is 3 times more common in mandible than the maxilla. Cortical swelling, pain, trismus, paresthesia may be present. Radiographically, unilocular or multilocular with well-defined border and area of bone destruction can be present. Differential diagnosis of mucoepidermoid carcinoma are cystadenoma, adenosquamous carcinoma, polymorphous low-grade adenocarcinoma, primary or metastatic squamous cell carcinoma, adenocarcinomas not otherwise specified, and cystadenocarcinomas, clear cell carcinomas, necrotizing cytometaplasia. Clinical behavior and prognosis. Recurrence rate, overall recurrence rate is about 25%. Most tumors recur within 1 year of therapy. Metastasis depends on the histological grade, clinical stage, and a specific site of origin. Most frequent from submandibular tumor, and distant sites involved are lung, skeleton, and brain. Prognosis, closely related to the clinical grade and histological grade of the tumor. Age and sex of the patient also influence the prognosis. Tumors in base of the tongue and floor of the mouth, tumors embedded into the bone, and tumors in submandibular gland have poorer prognosis. Low grade lesions have a 5-year survival rate of 92%, whereas intermediate and high grade have 49% survival rate for 5 years. Into the treatment part, is predicted by the location, histopathological grade, and clinical stage of the tumor. Surgical excision is the treatment of choice. Subtotal parotidectomy for early stage parotid tumor. Salivary gland removal for the advanced tumor. Wider resection done for high grade tumor. Radical neck dissection is indicated for cervical node metastasis. Postoperative radiation therapy may be used for aggressive tumor.